good. Right, well, it's 5 after, so why don't we go ahead and get started. So I wanted to welcome everybody to this year's Socolow lecture. I think this is our 5th annual now. The lecture is named in honor of Maurice Socolow, who was the first chief of cardiology here at UCSF until 1974. Soki, as his friends and colleagues called him, was part of the UCSF community from 1936 until 2002. He was a product of UCLA and UC Berkeley and a graduate of UCSF Medical School in 1936. Aside from a few brief stints, one at New England Medical Center and a second at Michael Reese Hospital for residency and fellowship, he spent virtually his entire career at UCSF. Among his many contributions, Soki was a founding member of the UCSF CBRI, where it was one of the first institutes in the country merging clinical cardiology with academic and research work. Soki was a creative researcher and teacher. His research focused primarily on hypertension. He designed and developed the first ambulatory blood pressure device and was responsible for first describing white coat hypertension. Layla will introduce Dr. Noel Bairey Merz, this year's Socolow lecturer. But before turning it over to Layla, let me extend my thanks to Noel for joining us in advance. So Layla.
Yeah, thank you, Dr. Olgan. I'm honored to be able to present today Dr. Noel Bairey Merz, who will be giving the Socolow lectureship. Dr. Bairey Merz holds the Irwin and Sheila Allen Chair in Women's Heart Research and is director of the Barbara Streisand Women's Heart Center, the Linda Joy Pollan Women's Heart Health Program, the Erica J. Glazer Women's Heart Research Initiative, and the Preventive Cardiac Center at the Cedars-Sinai Heart Institute. She also is professor of medicine at Cedars-Sinai Medical Center. Dr. Bairey Merz's research interests include women in cardiovascular disease, mental stress and heart disease, and the role of exercise and stress management in reversing disease. A prolific lecturer and member of many professional organizations, Dr. Bairey Merz has received numerous investigational grants, and she chairs the NIH-sponsored WISE, or Women's Ischemic Syndrome Evaluation Initiative. Dr. Bairey Merz has received numerous awards and honors, and her extensive scientific publication record spans over 425 scientific papers, myriad book chapters, and countless peer-reviewed journals. Dr. Bairey Merz earned her bachelor's degree at the University of Chicago, her medical degree at Harvard University, and she completed her residency here at UCSF, where she served as chief medical resident before she completed fellowships in clinical cardiology and nuclear cardiology at Cedars-Sinai Medical Center. We're very excited to have her here today giving the Socolow lectureship. And with that, I'll turn it over to you, Dr. Bairey Merz. Thank you so much, and the floor is yours.
What a warm welcome. Always great to be among friends. As many of you know, I'm a UCSF alum. I see a lot of familiar names. I don't see your faces, which is probably fine since we don't want to overburden the Wi-Fi. And I've prepared sufficient time that we should be able to chat about this and take questions. So I was asked,
I am arguing that we're going to start earlier.
Go on mute. This is the mantra of our pandemic, isn't it? You're on mute, or no, get on mute. So women in ischemic heart disease update 2022. So, all right, why am I not advancing? I've got to get my clicker over here. There we go. These are my financial disclosures. As far as I'm concerned, they don't pose a conflict to this topic, but of course we always disclose. Well, I thought I would talk about women in ischemic heart disease and introduce you to our INOCA-MINOCA program. You've probably been seeing these terms in the journals. They're relatively new. INOCA, of course, stands for ischemia with no obstructive coronary disease. MINOCA stands for myocardial infarction with no obstructive coronary disease. Many of us just got back from the American Heart Association scientific sessions in Chicago, And I was updated by a colleague who's a coder, and their request to enter these new terms as new ICD-10 diagnoses is apparently being favorably, they went and they presented, and the coders asked for more information. So this might be, I'm kind of on the fence about it, I have to say, when she told me about it, because they're kind of conditions, you know, they're like the metabolic syndrome, they're not really specific diagnoses. But that's news. So we may have codes, which I guess would increase awareness. So we'll see where that goes. Why did we get started on all this? Because back in the day, in the 1990s, National Heart, Lung, and Blood recognized an epidemic of cardiovascular death in women. For the first time, many of these large data sets were sex stratified. This is a slide from 10 years later. And these were studies that had angiographic core labs, so we didn't have to guess about whether or not they were over or underestimating the percent stenoses. And it was a big wake-up call that the prevalence of normal or non-obstructive coronary disease was actually pretty common in women, typically less than 10% in men. And because at the time the focus was predominantly on men, I always say in men, for men, and by men, we just didn't really recognize that this was not true. It was not uncommon in women. In fact, it was pretty darn common. Well, fast forward now a couple of decades, it's turning out to be pretty common in men. So this is data from Tom Maddox and his group when they were at the VA. This is the VA CART registry. For those of you that are unfamiliar with that, every single Veterans Administration hospital that does diagnostic coronary angiograms is part of this registry. And so you can see at the time of this publication, it was more than 37,000 coronary angiograms done predominantly in male patients, even though one out of 5 soldiers now is female. They have not aged yet to be substantial in our Veterans Administration hospitals, and also not of the age that you would be doing coronary angiograms. So at the time, this was an analysis of predominantly men, and 47%, 1 out of 2 of these angiograms demonstrated non-obstructive coronary disease or normal coronaries in men. And if any of you still rotate out to the VA, as I did when I was at UCSF, you know that nobody stays late to do an unnecessary angiogram. So these are presumably angiograms that were done for a reasonable clinical suspicion of that treating cardiologist. And why is this now becoming common in men? Peter, Libby, and I discussed this. I think declines in cigarette smoking in our seniors, widespread use of over-the-counter aspirin, widespread prescription of statins by our primary care workforce, and then better blood pressure control, drugs, right? I mean, we do a better job. The likelihood is that the phenotype or the character and quality of atherosclerosis is changing in men to be a more female pattern, if you wanted to call it that. But anyway, the point is, the stuff that we've learned about women's ischemic heart disease in these last several decades likely will be relevant increasingly to men. So that should be useful, and we want to take care of everyone, of course. So mechanisms of myocardial ischemia, including INOCA, of course, all the way to the left of this slide is what we know and love and what we're pretty darn good at: atherosclerotic obstructive coronary disease, stable plaque, vulnerable plaque. We have demand ischemia, we have plaque rupture, and or flow ischemia. And we've got optimal medical therapy, we have PCI, we have bypass, we have occluder devices, we have all sorts of good things for that. In the middle of the slide is vasospastic coronary disease, which used to be called Prince medals, or at least the sentinel cases were described by Myron Prince medal. And these are the epicardial coronary arteries that have the smooth muscle that are capable of doing smooth muscle mediated coronary vasospasm. And it turns out, at least in our big data sets, as well as others, if you bother to do the testing, it's probably less than 5% of the folks that will present with angina and evidence of ischemia. So while it's real, it's probably not a dominant form of ischemic heart disease. And it's also pretty easily treated with calcium channel blockers. So these are the patients that you figure out what the problem is, you give them a calcium channel blocker and they see you once a year for refills. And when you try to take it away, they say, no, 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 I need it. So what was the dark side of the moon is all the way to the right of this slide. And the coronary microcirculation and this idea of microvascular dysfunction. The hypothesis was that it impaired coronary physiology and myocardial blood flow, that it was triggered by cardiovascular risk factors, some of which were known, some of which are maybe not known. And this idea that this could be a root cause of signs and symptoms of ischemia. Signs would be an abnormal stress test or an abnormal troponin rise and fall. Symptoms would be angina or exertional shortness of breath. And that at a maximum, it was hypothesized that maybe this is an underlying root cause of Takotsubo, which was being described around the time, again, in the 1990s and early 2000s. So that was sort of where we got started. Of course, as you can see at the bottom, these three mechanisms can overlap. So one of the things as we set up the Women's Ischemia Syndrome Evaluation, again, fondly the acronym WISE. Why did we only study women? Well, because NHLBI told us we could only study women. The concern was that if we also tried to study men, we would fill up with men, which was kind of how most registries at that time were happening. And then number two, we said, well, hang on, I think, we think the microvasculature is probably important, including in obstructive coronary disease. For those of us that, learned how to do coronary angiograms, this idea of collaterals and, why somebody with left main didn't die was pretty important. And collaterals would probably be the small vessels, the microvasculature. Again, NHLBI said, let's keep it clean. We want you to study women only with open arteries. So that's what we did. They were the funding sponsor. We know, and this is old coronary physiology texts, but we don't teach this very much anymore. But back in the day, when coronary artery disease was a more physiologic oriented practice, we've always known that epicardial coronaries normally contribute less than 10% of the coronary vascular resistance, and resistance, of course, determines flow. And any cardiology fellow knows hemodynamic significance occurs when greater than 70% of that lumen is obstructed by an atherosclerotic plaque stenosis. The coronary microvasculature, on the other hand, is responsible for greater than 70% of that coronary resistance under physiologic circumstances. And so, it would make sense with this knowledge and this data that, in fact, what we're talking about is microvascular dysfunction anytime you have ischemia. So let's go through it one more time. Determinants of coronary flow. I've drawn here a left coronary artery that is an epicardial coronary artery. Again, remember, they're medium-sized arteries. They have smooth muscle in their wall. They're capable of vasoconstricting and vasodilating in a muscular, smooth muscle sense. They will dilate in response to nitroglycerin, acetylcholine, as well as shear stress. So they're dependent on these triggers to tell them what to do. The next, and what we've been talking about in microvasculature, are the intramyocardial arterioles. So these are actually embedded in the muscle. It's the next layer down of the smaller vessels, and they are precapillary, although the capillaries are part of the microvascular system as well. Now, these are auto-regulating in the site next to the cells, and they are highly responsive to the intramyocardial cell concentration of metabolites. So when the cell says, I'm a little acidotic right now, I need my ATP needs a little recharging, help, I need oxygen, they will dilate and be responsive and direct flow in that area. They are responsible for metabolic regulation of the coronary blood flow. And this small vessel is, the way that we test for it is adenosine. And adenosine, they have a little bit of smooth muscle, and then when they become even smaller, they don't have smooth muscle. Needless to say, water goes downstream, gravity controls a lot of things. You cannot have good flow, you cannot perfuse your subendocardium if you're going against a high pressure gradient. And again, as physiologists, and then cardiology turned into anatomists, we stopped measuring LVEDP. Echoes were just as good, right? If you wanted to know if the ventricle was dysfunctional or if there was a valve problem, check the echo. You don't need to put a pigtail down there. So we've sort of reinvested that, and always measure LVEDP in these INOCA and MINOCA subjects, because sometimes you'll be surprised at how elevated it is. And this is, of course, in the absence of a cardiomyopathy, valvular dysfunction, etc. So fast forward now, we, again, using acetylcholine and using adenosine as provocative agents in invasive coronary function flow reserve testing, we've demonstrated with our 10-year all-cause mortality follow-up in our women with signs and symptoms of ischemia. So this is that original WISE cohort. And they all had either no obstructive disease or normal coronary arteries, and it was about 50-50. That an impaired microvessel dilation. So in response to that intracoronary adenosine, although you can do peripheral as well. The reduced coronary flow reserve, the lack of dilation of those small vessels, portends an adverse prognosis in MACE, which is non-fatal MI, non-fatal stroke, hospitalization for heart failure, as well as death, cardiovascular death, and all-cause mortality. So this is the more dangerous pathway. Increased epicardial coronary constriction in response to the intracoronary acetylcholine predominantly predicted symptoms and recurrent angina hospitalization. So, and this is a bit of, why would you care? Why would you go forward and do this kind of testing? Why would you like to make these diagnoses if the ICD-10 codes come into play of INOCA and MINOCA? And this is the slide that tells you, yeah, we probably need to be paying attention to this because on the one hand, this prognosis is bad, and this is the kind of things that we have tools probably that can intervene. And this one is expensive, plus it erodes quality of life. All right, so if I've started to convince you about how you might want to start paying attention to these INOCA and MINOCA patients, let's talk about case selection and who do you want to pay attention to as a cardiologist. We all know there's a lot of causes of chest pain, and most causes of chest pain are not ischemic heart disease. So they've listed here pericardial pain, pulmonary, musculoskeletal, GI, psychiatric. So what you really want to be paying attention to is, and this is outlined pretty nicely now in the new ACC-AHA chest pain guidelines headed by my colleague, Dr. Martha Galati, that, it appears to be cardiac chest pain. We're not using the term atypical chest pain anymore. That appears to have harmed women. So it's either you think it's cardiac chest pain or not. And if your primary care doc has done this workup, then you're good to go, because to have a high level of suspicion that any symptoms above the waist could be due to ischemic heart disease, given that 1 out of 2 Americans has cardiovascular disease, it's not crazy to think that these should be investigated. So we still start with non-invasives because if we can figure this out without the provocative invasive testing, of course, that's always preferable in terms of risk benefit. So is the patient able to exercise? Is the baseline ECG interpretable? Then yeah, we still do exercise treadmill testing. And we look at all of these parameters. If it elicits the patient's symptoms, that is an ischemic response. Might be nociception, but you need to at least consider that it is ischemic. We look at the ECG. This is, when the ST segments go down, it used to be called cardiac syndrome X. We don't call it that anymore because now we think we have a pretty good idea about what it is. We also look at METs and functional capacity, and patients that can't get out of 2 stages of a Bruce protocol, that is not normal. And while it could be obesity and lack of fitness, it could be ischemic heart disease. So again, you need to pay attention to that. Arrhythmias, of course, that would be if they're significant, as well as a hypertensive response to exercise. So these are all things that we will be looking at. If the treadmill is inconclusive, or they can't do it, or there's persistent symptoms despite a quote normal treadmill, we will add at times advanced imaging. Why? Why don't we do stress echo and stress SPECT? They tend to be insensitive for small vessel dysfunction. Why is that? Well, both of these modalities, stress echo and stress SPECT, are dependent on one wall being normal so that you can see that the wall in comparison is abnormal. For SPECT, pixel density is down here, but it's compared to the other area. And that's why sometimes we get faked out, right, with triple vessel disease. We don't see it. Well, microvascular dysfunction is kind of like triple vessel disease. Everything is down. And so we typically, if we do reach for advanced imaging, we're going to do a PET, coronary flow reserve, or an adenosine stress MRI. And these are, of course, advanced imaging, sometimes hard to get authorized. Some authorization tricks are if the patient is overweight, or if the woman is large-breasted. These are sometimes useful for getting these tests authorized. The PET, of course, has radiation and is not universally available. The MRI is also not universally available, although most centers of excellence now have MRI, but they're not always so good at the perfusion. They're better anatomists. So these are not always routinely available, but it is our approach if we feel like a non-invasive will be helpful. This is an example of one of our cardiac MRIs. This is a patient that had rolled in with an NSTEMI, and you can see here her black rim. So here's her late GAD. The GAD is coming through, and then this black rim of her subendocardium is her microvascular coronary dysfunction. And it's pretty cool when you can see that. And that we are continuing to work making MRI a little more user-friendly. There's some pretty nice software packages now that make the perfusion aspect, if you have good folks in that lab, they should be able to do this for you. When do we do the invasive coronary functional angiography? The patients should probably have some evidence of ischemia. They've either already been confirmed they have no obstructive coronary disease. Most of our cases are elective, meaning they're redo caths. They come from St. Elsewhere, and nobody could figure out why they leaked troponin, why they have persistent chest pain, or an abnormal stress test. We do, however, and we will do this for patients who have refractory symptoms to medical management without evidence of ischemia, kind of to clear the air, especially if folks are sort of frequent flyers in the emergency room. And then we also will undergo this for women of childbearing age. And the question is, should they be taking all of these medications? Or women that live farther away, rural, or even in a big city, but their local doctor thinks they're nuts and is prescribing barbiturates. It's obviously a case-by-case selection. It is an invasive angiogram. We have published safety data in the hands of an interventional cardiologist. We had a less than 0.6 to 0.7 serious adverse event. And so it's as safe, it's a little safer than PCI, and about as risky as a diagnostic. Functional coronary angiography, again, in the hands of an experienced interventionalist, we confirm that there's no obstructive CAD. Again, we get outside cases. So just a quick look-see and make sure that what we were told or what we saw previously remains true. We record LVEDP as I described with a pigtail. We always assess for chest pain with contrast infusion, and we try to have minimal pain or sedation medication. And again, we're testing for that abnormal nociception. Some people feel their increased heart rate and their increased blood flow in their coronaries as pain, as angina. And other than a quality of life issue, that's pretty benign if there's nothing else wrong with them. And sometimes this can be very reassuring. You have made a diagnosis of their chest pain and they can stop worrying about it. The patients get heparinized. We still use a Doppler flow wire, although that company is discontinuing it. So pretty soon we'll be using the IMR wires, and we confirm adequate coronary flow signal. Coronary flow reserve to adenosine, we still use intracoronary adenosine, but again, as I said, if your interventional cardiologist is used to doing peripheral, because of they like to do the FFR and do that peripherally, that works fine as well. It works a little different, and we've published that. You may want to adjust for heart rate. But coronary flow reserve is a velocity, is a ratio of a velocity, as you can see. And so you make your shots. We also do acetylcholine. So here's a baseline. You can see that the catheter is in the mid LAD. Here's acetylcholine, and an example, this is an epicardial coronary. You make calculations to see what the microvasculature is doing, but this is kind of a good graphic example of things that you sometimes see. And then, of course, squirt some nitroglycerin down the coronary artery and you see it plump up and dilate just fine. Here's the IMR catheters that are more user-friendly. They probably overestimate flow compared to the validations of a coronary flow reserve of less than 2 by PET or by intracoronary adenosine. So we're going to have to increase probably up to 2.5 as we start to use these IMR catheters. The other thing that it can be useful in the microvasculature, is an IMR greater than or equal to 25. That's the resistance, right? And you have in Northern California, Dr. Theron is publishing pretty extensively in this area. And the interventional cardiologists like these catheters because they're quick and you don't have to do all this positioning that we've been having to do with the Doppler. So I think this will be hopefully good in the sense that we'll have more people, A, familiar with the condition, B, having the tools that can make these diagnoses, and then hopefully improving patients' lives. Well, back to the 1990s, early on in the WISE, we received a supplement to do a brand new technique at the time, which was intracoronary ultrasound. And again, as much as cardiology has become anatomists and we become very anchored on those luminograms, you're not really seeing the wall. You're not seeing atherosclerosis. You're not seeing whether or not they have negatively or positively remodeled. And so this was new in the 1990s, and it was a real eye-opener because, again, remember, half of those patients that had absolutely no evidence of atherosclerosis, and then the other half had, luminal irregularities. 80% of these patients, when we did intravascular ultrasound, had atherosclerosis in their coronary arteries, sometimes extensive. And again, just not paying so much attention and also needing new tools to make sure that we weren't missing things. We also did at the time magnetic resonance spectroscopy. So this is a non-imaging form of MR. It's a research tool only, but it's a gold standard because when you interrogate that cell, it is looking at changes in the phosphocreatine and ATP ratios, and as well as pH. So it really tells you that the tissue is ischemic or not. And what we demonstrated in our WISE women with chest pain but normal angios is the majority of them had a similar signal of ischemic tissue in their anterior wall as folks that had greater than 70% obstructive coronary disease stenosis, and different from reference controls who had neither. So this was a New England Journal paper, and our conclusion was that myocardial ischemia is frequent in subjects with signs and symptoms, but no obstructive coronary disease. These are not false positive stress tests. And for those of you that trained earlier, cardiac syndrome X, as well as perfusion abnormalities, were often labeled in women as breast artifact or false positives. So again, it's just wasn't true when we used these new techniques. We also had 5 to 7 year follow-up now in the early 2000s, and we were able to demonstrate that major adverse cardiac events, again, death, non-fatal MI, non-fatal stroke, heart failure hospitalization as a combined 4-point MACE, was predicted by this abnormal coronary flow reserve with the intracoronary adenosine. So this was kind of important. And again, the threshold for our WISE women, the best for us in terms of these AUC curves was a 2.32, not 2 and not 2.5. Now this was again with intracoronary adenosine, the Doppler flow probe, so the methods kind of count. But certainly, as we go into this IMR phase, probably using 2.5, which, doctors always need to have thresholds for making diagnoses, we'll probably anchor on the 2.5. We also demonstrated in terms of mechanisms that this MACE was elevated in our INOCA subjects that had persistent chest pain in the setting of no obstructive CAD. This was a 2-fold increase in MACE, and this was not true. We had a small cohort of women with obstructive coronary disease, and whether or not they told you 1 year later, after that initial visit, 1 year later, if they still had persistent chest pain, it didn't make a difference in the obstructive coronary disease women, but it did make a big difference in the non-obstructive coronary disease. And we think that's probably because, again, these patients were being treated. They had all had angiograms. They were all under the care of a cardiologist, at least at one point. And this was, again, in the early 2000s when we were really getting to go with guidelines-directed medical therapy, right? So if you were lucky enough to see a cardiologist and they happened to be an FACC, they were probably using guidelines. I remember I'll get with the guidelines and all of the different quality initiatives. Where these women, they don't have a diagnosis. And so when docs have diagnostic equipoise, they will have therapeutic equipoise. They don't know what to do. And at that time, that was not unreasonable. It wasn't a known diagnosis. So 15 years of WISE studies, it appeared to us that mechanisms included coronary atherosclerosis and myocardial ischemia. We also had observational as well as some randomized intermediate outcome trials. I'll share those with you next. And they supported therapeutic strategies, at least for quality of life issues. The existing guidelines focused on symptom management. Current clinical practice is reassurance. This is benign. Therapeutic clinical trials were needed. Well, here's some observational data, and we're going to go back again to that VA CART study. This is, again, all these male veterans undergoing coronary angiography for signs and symptoms of ischemia. And what you can see is that folks with mild non-obstructive disease were much more likely to not be treated, either not have therapy initiated, or actually some of them were pulled off of their therapy because they had open arteries, which, again, probably made sense at the time. And yet their prognosis was not that good. So there were observational data that suggested that, treatment, optimal medical therapy might help. We also had observational data from a randomized controlled trial. This is the Scott Hart trial, where they randomized folks who were presenting to their GPs in the UK with angina, stable angina, and they were randomized to standard of care only, which was often stress testing, to standard of care plus what was new at the time, a coronary CT angio, where you actually see the walls. And what they demonstrated, and again, this was not, I'll show you, this was an observation within this clinical trial, but the clinical trial was positive for benefit. So they had an actual reduced rate of death from coronary heart disease or a non-fatal MI. Now, how did a CTA save lives, right? Well, here's the observation. In the folks that had the standard of care plus CTA, they were much more likely to have treatment changes. And in fact, most of them were preventive meds, aspirin, statin, hypertension management. They actually were placed on anti-anginal meds almost 10% of the time compared to basically not. And again, longer term follow-up demonstrated even better benefit. So the mechanism of benefit in these open artery people was to deploy optimal medical therapy. We also have data, again, observing a randomized controlled trial from the famous or infamous Orbita trial. And for those of you that may or may not remember that, again, those crusty cardiologists in the UK, it was actually a young female fellow. This was her research project. They randomized 230 participants, women and men, to be randomized. They all had to have a PCI eligible stenosis for their chest pain. And they agreed to be randomized to PCI versus a sham PCI. They actually had the angiogram. They actually put the catheters in, gave them some heparin, but did not do the PCI. And then, as you know, here's what they found. The SAC, Seattle Angina Questionnaire, a valid metric in women and men for extent and severity of angina, did not differ between the two groups. And it wasn't because the PCI didn't work, it's because the placebo also worked. And it wasn't because they didn't improve ischemia. Compared to placebo, the PCI improved stress echo by over one segment. So opening up epicardial coronaries does improve blood flow to that segment of the heart muscle, but it doesn't improve angina. And why is that? Remember, in the very beginning, who controls blood flow? The microvasculature. And opening up epicardial stenoses in general does not solve that problem. We also did our own series of what we called pharmacologic probe trials, prospective, randomized, and then blinded at the core labs. And so we took, as you can see, sample sizes of 128 all the way down to 20. And we tried things that we just had off the shelf. Here, this is a good idea. Let's try this, let's try this, let's try this. And so what you see is that ACE inhibitors improved coronary flow reserve and improved angina. Who knew ACE inhibitors were anti-anginal in this setting? Hormones didn't work. Eplerenone adding on to the ACE did not work. A PD-5 inhibitor did not work. An initial pilot study of ranolazine, the newer anti-anginal, did work, but a larger study of a more heterogeneous population did not work. So we also, while we were planning our Warrior trial, the Core MICA trial came out from Scotland, Colin Bairey and his colleagues. They took, again, folks that were being referred by their primary care docs to coronary angiography for their stable angina. And again, similar to the VA CART, this was a mixed cohort of women and men. that about half of the angiograms had obstructive coronary disease. This is true in the US too now. You might look at your own cath lab registries, but so the half that had no obstructive coronary disease then were randomized to the regular angiography, blinded and sham controlled, and then coronary function guided. And the treating physicians who were not the interventional cardiologists who did the angiograms, the treating physicians were given basically a treatment sheet that you failed to dilate, you use alpha beta blockers. If you overly constrict, you use calcium channel blockers. And this is on a platform of optimal medical therapy. And what you can see is that the Seattle Angina questionnaire scores popped up very nicely, meaning their chest pain was improved with this relatively short randomized controlled trial. This is their treatment sheet. It's pretty complicated, so I've made it easy for us. They had the treating physicians consider optimal medical therapy. Most of these patients had atherosclerosis, which is aspirin, statin, and ACE, and therapeutic lifestyle change, cardiac rehab, and then, as I said, reduced dilation, alpha beta blockers, as well as some of the negative inotrope calcium channel blockers. Add-on therapy is listed. If they had increased vasoconstriction, calcium channel blockers, up-titrated, add-on nitrates, although we don't use long-acting nitrates very much because of the nitrate tolerance problem. And then adjunctive therapy. EECP, external counterpulsation, is effective and covered by insurance. High-intensity interval training at cardiac rehab or with a trainer. And then for the nociceptive abnormality, which can be concomitant with actual microvascular dysfunction, we can use the tricyclic low doses. So we used all of these to sort of build our case for designing and implementing the Warrior, which is the women's ischemia treatment, reduces events in non-obstructive CAD. The investigators are as listed, and we are randomizing 4,422 subjects, all women with angina and no obstructive coronary disease, randomized to intensive medical therapy, which is in high intensity statin, maximally tolerated ACE or ARB, low dose aspirin, versus a usual care of guideline directed risk factor management, hypertension, smoking cessation, et cetera. And the outcome is all-cause MACE, all-cause death, non-fatal MI, stroke, hospitalization for angina or heart failure. The flow diagram is here. Again, it's open label. It's a point of care randomization. The patients receive in the intensive medical therapy arm the medications by mail to their home. During the pandemic, we rapidly switched to online consenting, online enrollment, sent to Quest for their study safety labs. And we're still actively enrolling. So I'm always looking for folks. We're over the hump. We're up to almost 2,200, but of course, we were delayed by the pandemic. And so we're always looking for folks to enroll, and happy to enroll them at my site or happy to enroll them at your site if you guys are active. And the high intensity statins, of course, are Rasuva and Atorva, and maximally tolerated RAS blockade, losartan or lisinopril. It's also, we don't replace drugs that they are happy on. Again, it's a point of care, super easy, does not interfere with their own personal care and their own personal physician. So if they already have their own ACE or ARB, and also if they think that they're statin intolerant, you've already tried it, that's fine. We can give them ezetimibe. We have a few on PCSK9 inhibitors. So it is an open label, and it is a strategy trial, so they don't have to take what they're randomized to. We're getting good group separation as per our DSMB. And this is, if you wanted to take a picture, I know this is being recorded. I'm always interested in hearing about additional enrollees as well as additional sites. And I think that's my last slide. It is. So I'm happy to take questions if that's on the agenda. Thank you.
Thanks so much, Dr. Bairey Merz. That was a great talk. So yes, if anybody has questions in the audience, please leave it in the chat box or raise your hand on Zoom. And like I mentioned in the chat, if you prefer to keep the questions anonymous, you can also direct message me and I can certainly ask them on your behalf. We did have a question from the audience. Someone was wondering if you could talk a little bit more about aspirin use in Minoka. I know you mentioned it, but perhaps specifically in patients who don't have any evidence of coronary artery disease, should we still be using it?
Yeah, that's a great question. And I wish I knew the answer. And we'll do subgroup analysis of the Warrior when we get finished. And we have good adherence data about who is taking what. So we'll see. Pathology samples from Renu Vermani, when she used to do stuff other than stents, did demonstrate in younger females with plaque rupture, but microvascular microvascular obliteration was capillary loss. Women are more prone throughout their lifetime for thrombotic events. Deep venous thrombosis, pulmonary embolism is a good example of a really pretty important sex difference. So we threw in the aspirin without a lot of evidence, but it was part of optimal medical therapy. So I think that's a very good question. What would I do right now when I see patients in clinical care? It's a shared decision. Women, remember, I'll say one other thing. Women back in the Nurses' Health Study, remember the two studies that really put low-dose aspirin on the map were the Harvard Physicians' Health Study and the Harvard Nurses' Health Study. And if you remember, low-dose aspirin prevented first stroke in women starting at the age of 50. And if you think about most stroke, again, it's lacunar, it's small vessel. So that's the data that we have. And it's obviously not adequate, but hopefully we'll continue to ask these questions and advise. The point of the Warrior is to advise guidelines, to have guidelines in this area. Thanks.
Great. And then Dr. Grandis, you had a question. I'm wondering if you would be able to unmute yourself to ask the question.
Thank you. And what a wonderful talk and great body of work. My question for you is on how to non-invasively diagnose microvascular dysfunction. And I know insurance coverage is always a challenge, but if that were not the issue, what is your approach and your preference?
So we take sort of the small, medium, and large approach. So small is conservative empiric therapy, and particularly for patients that are in their 60s, they have existing risk factors, their hypertension, they're dyslipidemic, they might even be overweight, unfit, insulin resistant. And the idea is that they probably have endothelial dysfunction. There's pretty good data about that. And of the endothelial pathway, that's the acetylcholine testing pathway. It is most common that is an abnormal pathway in patients with signs and symptoms of ischemia, but no obstructive coronary disease. So the conservative is just aggressively treat their risk factors and, optimal medical therapy. So we really push the high intensity statins, maximally tolerated ACE or ARB, and a low dose aspirin. If they still have angina after all that, and you've sent them to cardiac rehab, start using anti-anginals. And, we use a lot of carvedilol. In my personal bedside experience, this is not randomized controlled trials, women in particular tolerate like the heart failure carvedilol low dose BID and then go up. Or calcium channel blockers and the diltiazims and the verapamils seem to be preferred over the amlodipine, although, individual. So that's small. Large is take them to the cath lab, right? And we do that for open artery infarcts. We do that for those young women who they really need to know. We do that for people that live remotely. The state of California is pretty large. The West is pretty large. And if it feels like they're having a heart attack, should they really, spend 2 hours trying to get to an emergency room? So we do the invasive testing selectively. And then the in-between, if you have an exercise treadmill test or even a routine image like an echo or a SPECT and it's abnormal, that's a pretty good diagnosis if you know their arteries are open. There aren't that many false positives when you actually sit down and look at it, as we've demonstrated in the WISE. And so again, just treat them. And if that is uncertain, as they said, try to get a PET or an MRI. I hope that helps.
It did. Thank you very much.
Great.
I'm curious, do we have a sense of how often we're doing some of these tests for INOCA, things like the PET-CT, MRI that you mentioned, or even invasive studies for coronary flow reserve? I guess it's a hard question to answer, but I'm just curious how many women in particular get delays in their care because of that.
Well, again, you have to be careful about delays in care because even these tests are imperfect, right? Non-invasives are always a bit of a health care bargain, right? So they're what you lack in risk, you sometimes lack in sensitivity and or specificity. So we do a lot, but that's because of where we are. Dr. Viviane Ticchetti does a lot of PET. Oh, that's because she's at the Brigham and they really love PET at the Brigham. So I think you're going to find that most of this is done in centers of excellence. That's not to say that there can't be pockets where people are committed and set up a program, to address this. I have Italian colleagues who do LAD, coronary flow reserve with, transthoracic echo. And they can do it because people in Italy are still fairly lean and they can see it most of the time. So I think it really depends on where you are. It would be nice to see more, right? But that was certainly true of stents. People weren't all doing stents immediately. You had to go, you had to be trained, you had to figure it out. You had to, try to be safe. Yeah, we'll see.
Thank you. Dr. Tang, you had a question as well. Would you like to unmute and ask?
Sure, thank you. Thank you, Dr. Merz. Terrific talk. Really liked your review of the pathophysiology. So really like your data on the quinupro and decreasing the pain, chest pain, right? Mm-hmm. So does that mean we should probably push ACE inhibitor dosing more and perhaps de-emphasizing the use of diltiazem and calcium channel blockers?
So I think it just depends on, where you are in the line of referral. We mostly see patients now that are referred or self-referred, and most of them have failed calcium channel blockers that either their primary or the community cardiologist tried. And see, that's that 3 to 5% with Prince metals. You start them on a calcium channel blocker and they'd say thanks. And it's really a mixed bag about response to calcium channel blockers. Again, remember, you could be having steal phenomenon, right? Because if you dilate the big arteries, the small arteries are not opening up and getting stuck. So failing a calcium channel blocker doesn't mean that they don't have microvascular dysfunction. It just means that one didn't work. People that have more non-obstructive coronary disease, meaning up to 50% the luminal stenosis, they often will be more responsive to calcium channel blockers. Again, that's my bedside condition. So to answer your question, yes, Core Mica really demonstrated, and hopefully the Warrior will as well, that on a platform of optimal medical therapy, because again, if you think about it, statins and ACE ARBs are really disease altering if you take it long enough. And our quinupro study was 16 weeks. So they were better in 16 weeks. On a platform of optimal medical therapy, which is disease altering and will take some time, if they continue to have angina, you add on those anti-anginals. So that's how we do it.
Thank you so much.
And then Dr. Goldschlager, you had a question as well. Would you like to ask it?
I can. Hi, Noel.
Hi. I miss you.
And I miss you. Let me ask you something, because I know arrhythmias were part of what was looked at. I cannot intuit that microvascular would leave a substantial scar burden. Is that
Mhm.
correct or not? And if it is correct, I would think that arrhythmia production would not be all that frequent or important. Reasonable?
Good, very good point, but it depends on your definition of substantial. So Dr. Janet Way, my junior faculty, had a CERC paper 3 years ago where we do see late gadolinium scars in about 10% of these INOCA patients, and the vast majority of them were never told they had a heart attack. They'd been to the emergency room, 5 times, and they never were told that they had a heart attack. The scars were small, relatively small, not big STEMI scars. And then the only other thing I'll say is, again, back in the day when we were working with Renu Vermani on her pathology samples, she had in the freezer relatively young, meaning under the age of 55, women of sudden cardiac death. And they had, microvascular, they had tiny little infarcts and capillary obliteration in that area. And they had sudden death. And then last but not least, in our MACE, a quarter of the MACE is death. So,
Thanks.
Any other questions that we have from the audience?
Bill Grossman keeps raising his hand, but maybe he's just clapping.